latest update from the Ministry of Health in regard to the management of COVID-19 patients with the chronic diseases. First of all, what is coronavirus? Coronavirus is a large family of RNA viruses that causes illnesses ranging from the common cold to more severe diseases, such as the Middle East Respiratory Syndrome and the severe acute respiratory syndrome. The new strain of coronavirus was identified in December 2019 in Wuhan City in China and has been named by the International Committee on Taxonomy of Viruses as a severe acute respiratory syndrome coronavirus 2. The ICTV had determined that the SARS-CoV-19 is the same species as the SARS-CoV-1, but with a different strain. And according to the WHO, it has named the disease associated with SARS-CoV-2 infection as coronavirus COVID-19. And since the emergence of the 2019 novel coronavirus infection in Wuhan, China, it has rapidly spread across China and more than 200 other countries around the world. And most of the cases involved in the first cluster in December 2019 were linked to the large Wuhan seafood market. The original source for the COVID-19 transmission remain unidentified. However, available genetic and epidemiological data suggest that the COVID-19 is a zoonotic pathogen with possible spillover directly from the wildlife or via intermediate animal host or their products. Sustained human-to-human transmission have been identified and confirmed in China, where numerous healthcare workers have been infected in clinical settings with overt clinical illnesses and fatalities. Most of the cases have been associated with fever and respiratory symptoms, such as coughing and shortness of breath, while other cases are mild or subclinical cases. However, there isn't much information about COVID-19 to draw definitive conclusions about the transmission mode, the transmission of the virus mainly through droplet mode or less frequently through contact. It can be transmitted as well through aerosol in case of aerosol-generated procedure and close contact in indoor settings. عفواً الصوت واضح للجميع أو في مشكلة؟ تمام شكراً. Investigations are currently still in progress to assess how the COVID-19 is actually transmitted, and in some people, it can be transmitted despite being asymptomatic. However, researchers don't know how often this may happen. Now for the surveillance of cases definitions. The definition of a COVID-19 confirmed case is a person who meets the suspected case definition with laboratory confirmation of COVID-19 infection through PCR tests. First of all, the clinical presentation. If the patient with acute respiratory illness, such as sudden onset of at least one of the following, fever, cough, or shortness of breath, there are no criteria required, so this will be a confirmation of COVID-19 with a PCR test. And in case of the clinical presentation, a patient with sudden onset of at least one of the following, headache, sore throat, rhinorrhea, nausea, diarrhea, or loss of smell or taste. And in the last 14 days prior to symptom onset, this patient has met at least one of the following criteria that we just mentioned. And the criteria are had contact with a confirmed COVID-19 case or is working in or attending a healthcare facility where patients with confirmed COVID-19 were admitted. If any admitted adult patient with unexplained severe acute respiratory infection, either community-acquired pneumonia or hospital-acquired pneumonia, this will be a COVID-19 suspected case that needs to be confirmed using a PCR test. In terms of infection prevention and control, the principles of infection prevention and control strategies associated with healthcare with suspected COVID-19 are the following. First, early recognition and source control, application of standard precautions for all patients, implementation of empiric additional precautions, and management of exposure to COVID-19 in a healthcare facility. Also, the transportation of a suspected and confirmed COVID-19 patient, administrative controls, environmental and engineering control, collection of and handling of the laboratory specimen, environmental cleaning and disinfection after COVID-19 case, and infection control in radiological examination for a COVID-19 patient. In terms of early recognition and source control, we need to encourage healthcare workers to have a high level of clinical suspicions, activation of the respiratory triage, post signage reminding asymptomatic patient to alert the healthcare workers. Promotion of respiratory hygiene is an important prevention measure. Also, suspected COVID-19 patients should be placed in an area that is separated from other patients, and additional infection prevention and control, such as droplet and contact prevention and precaution, need to be implemented immediately. The standard precaution include the following: universal masking of all healthcare workers, patients, and the visitors, correct and consistent use of the available PPE and appropriate hand hygiene, also performing hand hygiene after contact with respiratory secretions, and PPE effectiveness depends on the adequate and regular supplies and proper selection and use of the PPE. Also, you need to ensure that environmental cleaning and disinfection procedures are followed consistently and correctly through cleaning of the environmental surface with water and detergent, also applying commonly used hospital-level disinfectant, such as sodium hypochlorite. It is considered an effective and sufficient procedure. Also, managing of patient laundry, food service utensils, and medical waste in accordance with safe routine procedures. We need also to ensure the prevention of needle stick or sharp injury. In addition, we need to ensure the following respiratory hygiene measures: universal masking of all healthcare workers, patients, and visitors in hospital area need to be followed. Also, covering nose and mouth during coughing or sneezing with tissue or flexed elbow for others. For the implementation of additional precautions, first, the contact and droplet precautions for COVID-19 suspected case. In addition to the previously discussed standard precaution, all individuals, including family members, visitors, and healthcare workers, should apply contact and droplet precautions. The standard precautions should always be applied at all times. Also, placing the patient in an adequately ventilated single room to prevent transmission. Also, it is preferred and strongly recommended not to cohort a suspected COVID-19 patient because it can carry a risk of transmission of infection between the patients if one of them is well-confirmed case. In case of severe shortage of a single room, it is possible to cohort the suspected COVID-19 patient together with a strict adherence to the following standard. First, one patient only should be admitted in each multi-bed room. Then another patient will be put to bed far from the first patient bed, and so on until the need to admit patients in all the beds of the room. Also, there must be a physical separation between the patient's bed, single-use curtains, also mobile or fixed partitions, And in the event of unavailability, the distance between the bed and the other bed need to be at least 2 meters. And in case of severe shortage of a single room, it is possible to cover the suspected COVID-19 patient with the following. It is strictly forbidden to implement aerosol-generating procedures such as respiratory suctioning and nasopharyngeal swabbing in this cohort room. The patient should be directed to a single room in these cases. And if the mobile HEPA filter device are available, a device can be placed between each of the 2 beds of the patients. Strict adherence by healthcare workers to infection control practices, hand hygiene between patients, new gloves between patients, wearing a new set of personal protective equipment if the worn one set becomes visibly soiled, and never share the patient care equipment between patients, and it is preferable, if available, to use single-use equipment that are disposable afterward. Also, patients should be asked to wear surgical masks throughout their hospitalization period, as they are required not to move in the rooms between beds and corridor. Also, use a surgical mask with an eye facial protection, such as goggles or a face shield. Also, using gloves and a clean, non-sterile, long-sleeved, fluid-resistant isolation gown is required. Healthcare workers are advised to remove the PPE after caring for a patient in a proper way, then dispose it. After that, hand hygiene must be performed. And a new set of PPE is needed when care is given to a different patient. Using either single-use disposable equipment or dedicated equipment such as the stethoscope, blood pressure cuff, and thermometers need to be used as single-use or disposable equipment. If the equipment needs to be shared among patients, clean and disinfect between each patient used with alcohol that is 70%. Refrain from touching eyes, nose, or mouth with potentially contaminated hands. Also, avoid the movement and the transport of patients out of the room or area unless medically necessary. Also, using designated portable X-ray equipment or other important diagnostic equipment with cleaning between each patient. If you need to transport the patient, notify the receiving area of necessary precautions as soon as possible before the patient arrival. Use predetermined transport routes, get help through the security to minimize the exposure to staff and others, and apply surgical masks to patients. Also, transferred patients should not wait in the waiting or the recovery room to reduce the contact time as much as possible. Also, isolating signage should be hanged to the patient transportation equipment, and healthcare workers should ensure who are transporting the patient to wear PPE. And routinely clean and disinfected patient contact service with the Ministry of Health approved disinfecting procedure should be followed. Also, we need to limit the number of healthcare worker, family members, and visitors in contact with the patient with suspected COVID-19 infection. And we need to maintain a record of all persons entering the room, including all staff and visitors, such as communication tools like mobile. For airborne precautions for aerosol generating procedure for a suspected COVID-19 case, some of the aerosol generating procedures have been associated with increased risk of transmission of COVID-19, such as nasopharyngeal swabbing, tracheal intubation, non-invasive ventilation, tracheotomy, cardiopulmonary resuscitation, manual ventilation before intubation, and finally bronchoscopy. For the healthcare workers who are performing aerosol-generating procedure should note the following. First, they should use a fit-tested particulate respirator. Always perform the seal check when putting on a disposable particulate respirator, and for nasopharyngeal swabbing, in case of non-availability of respiratories, the healthcare worker can use a surgical mask and a face shield during the process. Also, healthcare workers should use all available types of respirator that are not fit to him, should be avoided from the aerosol generating procedure, or they should use a BAPR, a powered air perforating respirator. Also, facial hair beard prevents proper respirator fit. They should either avoid the aerosol generating procedure or use a BAPR. Healthcare workers should also use eye protection, such as goggles or face shield. Also, they need to clean and non-sterile long-sleeved isolation gown and glove to be used. And if the gowns are not fluid resistant, they should use a waterproof apron for procedures with expected high fluid volumes that might penetrate the gown. Also, healthcare workers should perform procedures in a negative pressure room with at least 12 air changes per hour and controlled direction of airflow when using mechanical ventilation. And in case of unavailability of a negative pressure room, nasopharyngeal swab could be taken in a well-ventilated single room with portable HEPA filter. Also, they should limit the number of persons present in the room to the absolute minimum required for the patient care and support. For the management of exposure to COVID-19 case in a healthcare facility. Healthcare facilities should identify and trace all healthcare workers who had been exposed to a confirmed COVID-19 case and identify the risk category according to the Ministry of Health guidelines. For patients who are exposed to a COVID-19 patient, prior to diagnosis or due to the failure of implementing recommended isolation precaution, the following general guidelines should be followed to manage well dependent on infection control team risk assessment. First, for patients who are sharing the same room in any setting, either in a ward with a shared bed, in open ICU, or in the ER room, who've been in contact with a confirmed COVID-19 case for at least 15 minutes, the patient should be followed daily for symptoms for 14 days after exposure. Testing using nasopharyngeal swab or deep respiratory sample if intubated for COVID-19 is required, preferably within 24 hours or more after the exposure. And if negative on initial testing, the exposed patient should be retested again with RT-PCR if they develop symptoms suggestive of COVID-19 within a follow-up period. Patients who were discharged during the follow-up period must be reported to Public Health Department to continue monitoring for symptoms. In terms for transportation of a suspected and confirmed COVID-19 patient outside the hospital facility, if the patient who is suspected or confirmed will have to be moved safely between their homes to a healthcare facility, as well as from a healthcare facility to a dedicated COVID-19 management facility, the following should be followed. First, acknowledging the challenges vehicular transportation of such patient pose, including the vehicle contamination and infection transmission. Safe transfer is possible if the following recommendations are followed. First, there should be arrangement between the transporting facility and the receiving facility for transporting time, personnel, and clinical information. Second, the patient should be masked with a surgical mask during transportation. The patient should also must be health educated about respiratory etiquette, and the driver should wear surgical mask during the transportation also. Also, never transport a suspected case with a confirmed COVID-19 in the same vehicle. Also, using vehicles should be disinfected using the Ministry of Health guidelines, using alcohol wipe or spray with a freshly prepared sodium hypochlorite solution. The precaution during patient transport by an ambulance. Where possible, ambulance staff should carry out initial assessment, keeping a distance of at least 2 meters from the patient. And for additional staff protection, the number of ambulance staff in the patient section of the ambulance should be restricted to the minimum required. And the staff should notify the receiving healthcare facility that the patient has an exposure history and signs and symptoms that is suggestive of COVID-19, so that appropriate infection control precaution can be taken before the patient arrival. It is best to limit the contact with patient contact. Patient should be asked to wear a face mask if possible. It is placed on him or her. This face mask can reduce the ability of the patient to contaminate with immediate working environment of the ambulance staff. Also, oxygen delivery with a non-rebreathable face mask may be used to provide oxygen support during transport for those who need it. If needed, positive pressure ventilation should be performed using a resuscitation bag valve mask, preferably one equipped to provide HEPA or equivalent filtration of expired air. To the extent possible, staff should ensure that patients are isolated from other patients. This can include not allowing family members and others to contact to accompany the suspected and confirmed COVID-19 case in the ambulance. However, if they do accompany the patient, they must wear a face mask also. And in patients with nasal cannula in place, the face mask should be fixed over the cannula, and it is possible to use an oxygen mask when indicated. The ambulance with isolated driver and patient section providing independent ventilation to each other is preferred. And to assure that the driver isolation from the patient section, keep connecting doors and windows closed before bringing the patient into the ambulance. Also, during the journey, ensure that ventilation in both sections are in the non-recirculated mode in order to optimize the changes, thereby reducing the presence of potentially infectious particles in the ambulance. The ambulance with the rear exhaust fans can use it to remove the air from the vehicle at the back, and the use of it's preferable to use ambulance fitted with HEPA filter coupled ventilator when transporting the patient on mechanical ventilators. To use the ventilation in ambulance lacking physical isolation, driver section, open the outside air vent in the driver section that should be opened and the rear exhaust ventilation fan turned on to the highest setting. This can generate a negative pressure gradient in the patient area. And the ambulance staff should complete the handing over process at the destination healthcare facility following the standard procedure. In terms for the recommendations on personal protective equipment use, The ambulance staff providing care for or accompanying a suspected or confirmed COVID-19 patient in the patient section of the ambulance should adhere to the standard and transmission-based precautions, including the required PPE. Also, in situations where personnel driving the ambulance used to transport patients are involved in moving a patient into the stretcher or other forms of direct care, it is recommended that they strictly use a recommended PPE, including N95 mask and goggles. They should also appropriately doff and dispose their PPE and perform hand hygiene after completing the patient care and prior to re-entering the isolation driver section. This will prevent contamination of the cubicle. And in situations where the ambulance or vehicle lack an isolated driver section, it is recommended that the driver use a respiratory face mask during transport. However, the driver should remove his face shield or goggles, gown, and glove, and also perform hand hygiene after delivering the patient. Also, the ambulance staff should avoid touching their faces while working, and upon arrival at the healthcare facility and following the patient handover, ambulance staff should doff and discard the PPE and perform hand hygiene. They should discard the used PPE following the standard Ministry of Health procedures. In terms for recommendation relating to the patient care documentation, only after the ambulance staff have completed patient handover, PPE, and hand hygiene, they should proceed to patient care documentation. The recommendation regarding cleaning the ambulance after transporting a patient with a suspected or confirmed COVID-19. Once the patient has been handed over at the designated receiving healthcare facility, the ambulance should be aerated with several cycles of air changes by leaving its rear door open. This will get rid of possibly infected particles. And after the patient transfer, terminal cleaning should be done using manual method or hydrogen peroxide dry mist or vapor. Before cleaning the ambulance, the staff should do a disposable gown and gloves, eye and face protection, PPE, such as goggles, face mask, or face shield, are recommended if the cleaning procedure will generate splashes or spray. And environmental cleaning and disinfection should be carried out following the procedure consistently and correctly. This includes assuring adequate ventilation when chemicals are used by keeping the doors open. Routine cleaning and disinfection procedures, such as using cleaners and water to pre-clean the surface prior to applying approved disinfectant, to frequently touch surface or objects for appropriate contact time as indicated on the procedures lab, are appropriate for the COVID-19 in healthcare setting, including those patient care areas in which the aerosol generating procedure are performed. Following the approved procedure, the ambulance must be cleaned and disinfected, ensuring that all contaminated surface, including the stretcher, the rails, control panels, floor, walls, and work surface are thoroughly cleaned, approved disinfectant, and in accordance with the manufacturer instructions. Also, clean and disinfectant reusable patient care equipment before use on another patient according to the manufacturer instructions. And the ambulance staff should keep to approved procedure for the contaminant and disposal of their used PPE and regulated medical waste, as well as laundering used linen. And finally, they should avoid shaking the linen to prevent further spread of the virus. In terms for the follow-up and reporting process, the ambulance staff should carry out the follow-up reporting measure required for them to post care of a patient with a suspected or confirmed COVID-19 infection. Their supervisors should implement regulating requiring monitoring, excluding from work. And as pertains to the healthcare workers having potential exposure to COVID-19 infected patients, the ambulance staff are required to promptly inform their supervisors of their exposure to a patient with a confirmed COVID-19 infection, who can ensure that the appropriate action is taken afterward. And the ambulance staff are required to report any unprotected exposure to the patient with a confirmed COVID-19, such as not doing the recommended PPE or compromised or inappropriate PPE. They should report this to their supervisor or infection control department for appropriate evaluation and action. Ambulance staff are required to monitor and report any fever or respiratory symptoms such as cough, shortness of breath, or sore throat that develop after transporting a patient with a suspected COVID-19. And upon the development of symptoms, they should isolate themselves and inform their supervisor or infection control for appropriate evaluation and action. In terms for collecting and handling a laboratory specimen from a patient with a suspected COVID-19, all samples collected for laboratory investigation should be regarded as potentially infectious samples. And healthcare workers who collect or transport the clinical specimen should adhere rigorously to the standard precautions to minimize the possibility of exposure to pathogens. Also, they need to ensure that healthcare workers who collect specimens use appropriate PPE, such as eye protection, surgical masks, long-sleeve gowns, and gloves. The respiratory specimens should be collected under aerosol generating procedure. Personnel should wear a particular certified N95 respirator, and they need to ensure that all personnel who transport the specimen are trained in safe handling practice and spill documentation with procedures. Furthermore, they need to place the specimen for transport in a leak-proof specimen bag, secondary container that have a separate sealable bucket for the specimen, including a plastic biohazard specimen bag, with the patient name label on the container, the primary container, and the clearly written laboratory request form. Also, they need to ensure that the healthcare facility laboratories adhere to the appropriate biosafety practice and the transport requirement according to the type of organism being handled. Also, delivering the specimen by hand should be done whenever possible, and don't use a pneumatic tube system to transport the specimen. And HESN printed lab requisition must be sent with the sample and national lab reception report, and result values must be updated on the HESN on their corresponding time. In terms of infection control and radiological examination for a suspected or confirmed COVID-19 case. Chest X-ray for patients with a suspected or confirmed COVID-19 should be done at the patient room with a portable machine as possible as when we can, to limit the transportation of the patient, which may increase the risk of transmission of infection. Also, imaging patients with a suspected or confirmed COVID-19 should only be considered for emergent situations, as transmission-based precautions of contact, droplet, or airborne infection should be applied with the suspected case, depending on patient status and the procedure that need to be done. A portable radiographic machine should be used as possible to limit the transportation of patients, which may increase the risk of transmission of infection. Also, dedicated portable X-ray machine for isolation ward, ER, to minimize the risk of spread of infection, and when available, use a cassette detector single-use disposable cover to minimize the risk of spread of infection. It should also be highlighted in the imaging request that the patient is suspected or confirmed COVID-19 case, and the radiology technician should be trained from infection control department about the standard and transmission-based precaution, especially hand hygiene, proper selection, and use of PPE. Also, portable machines should be disinfected after each use with the approved Ministry of Health disinfectant and according to the manufacturer recommendations. For laboratory diagnosis, first, specimen collection and shipment of COVID-19 sample. All staff who will be handling the COVID-19 sample should be trained for appropriate collection, storage, packaging, and transportation. When collecting the specimen, avoid contamination. It is advised to have a sufficient quantity of sampling in case of repeating the test or performing further characterization. Also, you need to follow the appropriate precaution for safety during the collection and processing of samples. Testing is limited to qualified laboratories with a certified Class 2 BSc in a BSL2 facility and those designated by the Saudi CDC. To provide diagnostic testing for COVID-19, the lab should perform RT-PCR testing using the confirmatory test approved by the National Health Laboratory. In the current time, labs should not attempt viral isolation and culture from samples collected for patients with a suspected COVID-19. The samples that need to be collected for the lower respiratory tract samples, they need to collect endotracheal aspirate and bronchoalveolar lavage fluid or septum. For the upper respiratory tract sample, in adults, the sample that need to be collected include, whenever feasible, nasopharyngeal swab should be the first choice when collecting samples. And if nasopharyngeal swab is not feasible, nasal wash aspirate can be considered. And oropharyngeal swab can be used when both previous options are not feasible. Samples for children under 12 years of age include oropharyngeal swab should be considered, and if not feasible, nasal wash aspirate can be considered. And if this was not possible, a nasopharyngeal swab can be considered. Only flexible nasopharyngeal swab should be used. So swab is divided into two options for adult and for children. For adult, nasopharyngeal swab, nasal wash aspirate, and oropharyngeal swab. For children, the first choice should be oropharyngeal swab, nasal wash aspirate, or as a final choice, nasopharyngeal swab. The lower respiratory tract sample are preferred if the patient has signs or symptoms of lower respiratory tract infection, and if lower tract specimens are not feasible or clinically indicated, upper respiratory samples should be collected. Repeat the testing should be performed if the initial testing is negative and there is a high index of suspicions or symptoms. Also, patients should be retested using a lower respiratory sample, or if not possible, repeat the collection of a nasopharyngeal sample. And in HESN, you can register the case for the test requested, select COVID-19, and select designated laboratory. The HESN request form is to be completed and must be attached with the sample before sending it. A single negative test result, especially from upper respiratory tract sample, doesn't rule out the infection. And negative RT-PCR result must be interpreted in correlation with the clinical finding, history, and other diagnostic procedures. A positive RT-PCR for COVID-19 indicates the infection with the SARS-CoV-2. However, it doesn't rule out co-infections with other viruses. So the difference between the nasopharyngeal swab and the oropharyngeal swab, the naso, we need to proper selection of the sample collection stick. Stick tend to be thinner toward the tip, and we need to avoid using the stick with identification closer to the tip. For the oropharyngeal swab, proper selection of the sample collection stick, and the stick tend to be thicker than the nasal with a larger tip. After performing the test, we need to notify and result report on the HESN portal. All labs that are testing for COVID-19 are required to report all positive results immediately to the public health authorities through the HESN portal. And samples with positive results from Ministry of Health, governmental, non-Ministry of Health, and private sector should be sent to the National Health Laboratory, Saudi CDC, for further confirmation and characterization according to the updated memo regarding the number and frequency. Also, we need to store the respiratory sample at 2 to 8 Celsius degrees and ship them to the National Health Laboratory, Saudi CDC, on an ice pack. For storage and shipment of the samples, as we said, we need to store the samples at 2 to 8 Celsius and ship on ice pack to the NHL. The samples can be stored at this degree for less than 48 hours. If the sample needs longer storage, the sample should be stored at -70 degrees. And if the sample was frozen at a -70 and we need to ship it, we need to ship it using dry ice. And if the samples can be shipped free of charge by the carrier, SIMSA, following the appropriate regulation by the Ministry of Health. The carrier service is available for sample transportation and pickup location throughout Saudi Arabia for collection of samples from the Ministry of Health hospitals and other healthcare facilities. For this specimen pickup, it can be requested from SIMSA at the following number. All the samples must be appropriately packed, and the carrier service is provided 7 days a week. And the carrier will package and transport the samples in accordance with the transportation regulation from the WHO guidelines. For quarantine and homestay guidelines for contact. The decision to restrict the activities of contact or persons suspected of being infected or to separate them from one another, it depends on the assessment of the level of risk of transmission, the type of infectious disease, and the expected incubation period in a manner that leads to preventing the spread of the infection or contamination. Action that need to be taken during quarantine. We need to instruct individuals under quarantine that they shouldn't leave their home or facility quarantine in or contact with other unless for medical reason. Monitor the health status of the young without other comorbidities individuals under the quarantine every 3 days using the following form, and monitor the health status of the individuals with known comorbidity or old age under quarantine every day using the attached form also. We need to ensure that both the workers follow the precautionary measures such as washing hands and wearing a surgical mask. They should also disinfect all exposed surfaces and tools that are touched on a daily basis with disinfectants that are approved by the Ministry of Health by trained people who are wearing gloves, surgical masks, and medical gowns during cleaning. Also, when washing clothes of a quarantined individual is needed, personnel need to wear a protective equipment, including gloves, surgical masks, and medical gown, using a warm water and detergent for as long as possible, and finally drying them using the cloth dryer. Also, we need to ensure that the quarantine room is well ventilated with good airflow and safe disposal of the medical waste, and the supervisor of the quarantine should be informed in the event of fever or the appearance of respiratory symptoms in individuals under the quarantine or employees to ensure the performance of a proper medical evaluation and completion of the necessary procedures. For guidelines for individuals under quarantine, the healthcare workers should advise the individual under quarantine to adhere to the following points. First, to maintain hand cleaning by ensuring to wash them regularly with soap and water or using alcohol-based gel for a period that is not less than 20 seconds. Also, they need to ensure they cover the mouth and nose when coughing or sneezing using the tissue or upper sleeves, making sure that the throw the tissue in the trash and wash the hands immediately afterward, and to wear a surgical mask if other people are around, and avoid sharing personal utensils or other personal items. Criteria for recovery and discontinuation of isolation. For confirmed cases, if the patient was with severe infection, meaning the patient who are hospitalized at a non-critical ward with a laboratory confirmed COVID-19, these cases should isolate until the following criteria are fulfilled. First, at least 10 days have passed since the onset of the symptoms, and no recorded fever in the last 3 days without the use of antibiotic, and improvement of other symptoms, including cough, shortness of breath, and GI symptoms. The patient can be discharged before recovery based on clinical criteria. Their evaluation of the treating physician. Home isolation should be continued until fulfilled with the recovery criteria. For patients with severe infection who are immunocompromised and critical cases in the ICU, for those patients, isolation should last until one of the following criteria are fulfilled. First, at least 21 days after the symptom onset, and resolution of fever for at least 3 days. Also, clinical improvement of the symptoms other than the fever, such as cough, shortness of breath, and GI symptoms, or at least 3 days have passed since the recovery resulting from a fever without using fever-reducing medication, and symptoms improvement such as cough, shortness of breath, and GI symptoms, and followed by 2 negative respiratory samples more than 24 hours apart. For patients with mild confirmed cases who are confirmed with COVID-19 that were never hospitalized due to mild symptom or they were even asymptomatic. For those patients, they can end self-isolation after 10 days after the onset of their symptoms and the resolution of the fever for at least 3 days, and there is a clinical improvement of other symptoms. For asymptomatic patients who are confirmed with a PCR test, 10 days have passed since the date of the collection of the respiratory sample with the first positive PCR result. For the suspected cases, all suspected cases must be tested for COVID-19 using RT-PCR. And if clinically unstable, the suspected case must be isolated in a hospital until the results become available or the case is clinically stable for discharge. And if a suspected case is clinically stable, home isolation or isolation in a designated facility can be considered if home isolation is not possible based on the assessment of public health team and CC until the result becomes available. If the result is positive, the suspected case is considered as a confirmed case and managed accordingly. The admission criteria for COVID-19 patients who are confirmed or suspected with COVID-19, who are also symptomatic, plus any of the following criteria: clinical or radiological evidence of pneumonia, patient older than 65 years, patient with a low oxygen saturation less than 94 on room air, and patient with acute respiratory distress syndrome, and those who are having a chronic pulmonary disease. Also, patients with chronic kidney disease or those with a history of comorbidities such as diabetes or hypertension, and those with a history of cardiovascular disease or obese patients with a BMI more than 40, and those usually using biological immunosuppressant medications such as tumor necrosis factor inhibitors, interleukin inhibitors, and anti-B cell agents, and patients with a history of organ transplant or another immunosuppression disease, or those with a history of active malignancy and other co-illnesses that require admission should be admitted when they test positive for COVID-19. For pediatric patients, Ministry of Health recommends to admit any pediatric patient who meet the case definition of a confirmed or suspected COVID-19 who is also symptomatic plus any of the following high-risk criteria. The high-risk criteria are infants who are less than 1 year, clinical or radiographic evidence of pneumonia, those with oxygen saturation level less than 92, respiratory failure, or pre-existing chronic conditions such as chronic pulmonary disease, moderate to severe asthma, cardiovascular disease, chronic kidney, chronic liver, or neuromuscular disease, and those with endocrine disorders such as diabetes, and those with a metabolic disorder are considered as a high-risk criteria. Also, pediatric patients who are using immunosuppressors such as those with cancer or using chemotherapy, radiation therapy, hematopoietic cell or celluloid organ transplant, and patients with clinical features that are similar to the toxic shock syndrome and atypical Kawasaki disease, and patients with gastroenteritis, picture with dehydration or poor oral intake, and persistent high fever for at least 3 to 5 days, and disease course that is longer than 1 week with no improvement in symptoms or sign, and a progressive exacerbation, and patients with severe obesity with a BMI that is more than 120 percentile, and those home isolating or non-hospital-based quarantine facility is not applicable as per the Ministry of Health update guidance. So these cases are considered as a high-risk criteria pediatric cases and need to be admitted once tested positive for COVID-19. For the current Ministry of Health guidelines for COVID-19 management, the supportive care and antiviral treatment of suspected or confirmed COVID-19 case is based on the following. If the case is suspected case with a mild to moderate symptoms with no shortness of breath, they need to treat the symptoms using the following pharmacotherapy. First, if the patient was using ACI, RIBS, in patients with hypertension, post myocardial infarction, or heart failure, do not stop their medication. And as a precaution, they need to take paracetamol, which is the preferred agent for pain and fever, And the following lab tests should be done: CBC, urea electrolyte, creatinine, CRB, LFT, chest X-ray, and of course, COVID-19 PCR test. For patients who are suspected case, as we mentioned before, the definition of a suspected case, who are with a mild or moderate symptoms that doesn't have shortness of breath or aren't considered as a high-risk patient, according to the criteria that we just mentioned. First, we need to treat the symptoms, and if hospital admission is not required, we need to follow the instruction for isolation or quarantine, and we need to consult the infection disease specialist. For pharmacotherapy, the case shall be discussed with the infectious disease specialist to initiate empirical antiviral therapy while waiting for PCR results. And don't stop the ACIE or ARBS in patients with hypertension or having a cardiac disease. For paracetamol, it should be used as a precaution for pain and fever. Also, lab work that need to be done include CBC, urea electrolyte, creatinine, PCR, LFTs, chest X-ray, and of course, a COVID-19 PCR test. For patients who are confirmed with COVID-19 and are asymptomatic, there is no need for pharmacotherapy, and as a precaution, they can use paracetamol for pain and fever if present. And we could do the following lab work as previously discussed: CBC, urea electrolyte, creatinine, CRB, LFTs, chest X-ray, and COVID PCR test. For PCR confirmed cases with a mild to moderate symptoms, no oxygen requirement and no evidence of pneumonia, but other symptoms of COVID-19, such as fever, the following inclusion criteria are indicated for using oral antiviral. First, for patients who are aged more than 12 years and weighing at least 40 kilograms, they should use Paxlovid. And for those over 18 years, they should use molnupiravir. And for patients at high risk for progression to severe COVID-19, such as hospitalization or even death in severe cases, they should use antiviral within 5 days of the symptoms onset. The exclusion criteria for using oral antiviral: patients who are less than 12 years and patients who are less than 18 years for the molnupiravir, and for patients weighing less than 40 kilograms for the Paxlovid. Also, patients with a history or recurrent need for hospitalization or immediate medical attention in a clinical emergency room service due to COVID-19. Also, not to be used for more than 5 days if were used at all. The inclusion criteria for using the anti-SARS-CoV-19 monoclonal antibodies should only be used in patients with high risk for progression to severe COVID-19 or hospitalization. These criteria include a patient with a confirmed positive PCR in the last 3 days, and within 7 days of the symptoms onset, more than one sign and symptom of COVID-19 within 24 hours of following the following risk factor has appeared. Patients who are aged more than 65, obese patient with a BMI more than 35, patients with end-stage renal failure, sickle cell anemia, immunocompromising conditions, or chronic immunosuppressive treatment, or those who are aged 55 to 65 with cardiovascular disease, hypertension, diabetes, or chronic obstructive pulmonary disease. Also, for patients who have a blood oxygen saturation that is more than 92 and who obtained at rest by attending a physician within the 24 hours. Criteria for patients at high risk for developing cytokine storm. One or more of the following should be met: the elevated D dimer, that is more than 1 microgram, CRB more than 75, the serum ILL6 more than 3 times the upper normal limit, and ferritin more than 600 microgram at presentation, and LDH is more than 250, or if the ferritin was more than 300, and with a doubling within 24 hours of the result. The use of Snombro Prophylaxis, the following recommendation need to be met. All admitted patients should be evaluated upon admission and daily thereafter for both thrombotic and bleeding risks. Laboratory evaluation and monitoring for the baseline CBC, fibrinogen, BT, ABTT, the D-dimer on admission, and serially. Also, baseline surveillance imaging are not recommended in the absence of clinically symptoms of VTE. Patients on chronic VTE prophylaxis should continue as planned before the infection. Also, warfarin and antiplatelet medication are not recommended to be used as a prophylaxis. For patients whom anticoagulant therapy is contraindicated, mechanical thrombophylaxis is preferably with intermediate pneumatic compression device should be utilized, although there is limited evidence of efficacy in hospitalized medically ill patients. Also, thrombophylaxis should continue until the time of discharge at least. For continuation of anticoagulation is subjective to the assessment of VTE risk by treating medical team. Also, heparin-induced thrombocytopenia, platelets that are below 50 plus 109 liters, unexplained bleeding, inherited bleeding disorders such as hemophilia or thrombocytopenia, inherited red blood disorders such as sickle cell anemia, and previously on anticoagulant therapy, and finally radiological evidence of thrombosis. For adults, therapeutic doses should not be offered because of the risk of bleeding. And thrombophylaxis with a low molecular weight heparin should be considered in all patients, including non-critically ill, within 24 hours of hospital admission for a COVID-19 infection case, in the absence of any of the contraindications, such as active bleeding and platelet count that is less than 25. Also, monitoring is advised in severe renal impairment, and in abnormal BT or ABTT is not a contraindication. Also, enoxaparin prophylaxis doses should be at 40 milligrams subcutaneously given once daily. For obese patients with a BMI more than 40 milligram also subcutaneously, that is given every 12 hours. And for pregnant women, 40 milligrams subcutaneously once daily. For adults with renal impairment, CRCL more than 30 milli, there is no need to adjustment. If the CRCL that is less than 30 milligrams subcutaneously given once daily. And for hemodialysis and CRRT, they need to avoid the use if possible, but if used, anti-XA levels should be frequently monitored as accumulation can occur with the repeated doses. In high-risk patients, VTE score more than 4 or 2 to 3 with a dimer level that is more than 500, after hospital discharge, Abixine 2.5 milligram twice a day or rivaroxaban 10 milligram per day for 35 days should be considered. For pediatrics, infants who are 1 to less than 2 months of age, 0.75 milligram per kg dose subcutaneously should be given every 12 hours. And for infants who are more than 2 months of age, and children and adolescents also, a dose of 0.5 milligram per kg should be given subcutaneously every 12 hours. For pediatrics with renal impairment, no pediatric specific recommendation. They should just be used with caution and monitor the patient closely. And if the patient was on dialysis, not approved, but if used, the doses should be reduced and anti-XA level frequently monitored, as accumulation can occur with repeated doses. And in hemodialysis, it is not dialyzable and supplemental doses is not necessary. For patients with diabetes and the confirmed case of the COVID-19, first of all, the pandemic of COVID-19 is hitting the world hardly in a real catastrophic, not preceded for the last 100 years, and it can affect all ages group with no difference between the sick or the healthy individual. And among those affected by the virus are the people with diabetes who carry a great risk for having aggressive complication and poor outcome. In that context, the Saudi National Diabetes Center and Saudi Health Council came out with a summarized guidance targeting the health professionals in the management of diabetes during the outbreak of COVID-19. The vast majority of people who contract COVID-19 will experience only mild symptoms and can make a full recovery. However, people with diabetes or other long-term conditions are more likely to experience symptoms of a greater severity. And some of these may need admission to hospital or for a suspected care and more intensive intervention. And currently, the spectrum of disease suggests that 81% of the cases will be mild, 14% will be severe, and 5% will be treated as a critical case. The risk does appear to increase in people who are aged more than 70 years, particularly those with a comorbid heart disease, diabetes, or respiratory disease. The risk of comorbidities and mortality of people with diabetes and existing or probable COVID-19 infection. The findings from the confirmed cases of the disease from the Chinese Center for Disease Control and Prevention indicate that the overall case fatality rate was 2.3%, which represents 1,000 deaths of the 44,000 confirmed cases. The data indicated that the CFR was elevated among COVID-19 patients with pre-existing comorbid condition, specifically cardiovascular disease, diabetes, chronic respiratory disease, hypertension, and cancer. These data also show an age-related trend in the CFR, with patients aged 80 years or older having a CFR rate of 14%, and those aged 70 to 79 have a rate of 8%, while there were no fatal cases reported in patients aged 9 years or younger from the prevention from contracting the virus. The measure recommended by the CDC should be encouraged by the healthcare providers to their patients in particular to stay at home as long as possible and avoid gathering inside the home, to wash hands regularly with water and soap, to avoid handshaking, and they shouldn't expose to sick people. For outpatient management of diabetes to control COVID-19, from the previous experience, it seems that the ability to fight the infection and decrease the risk of severe infection in people with is correlated well with glycemic control. Therefore, it suggests that if the blood glycated hemoglobin level was below 7%, the risk of severe infection will be similar to the normal population. However, if the patient has other comorbidities like cardiovascular or renal disease, the risk will increase. Therefore, the target of the medical team is to encourage glycemic control before and during contracting the infection by the following measures. Secondary care services that may need to continue at full capacity, multidisciplinary diabetes foot service, pregnancy and diabetes service can be performed remotely as possible to avoid hospital visits. Primary care delivered diabetes services, implications for routine diabetes care should be considered in the context of broader long-term condition management and prioritization, and taking into account individual risk factors and clinical needs. Diabetes services should look to maintain and optimize the health of individuals within their services over the course of the pandemic, and should not underestimate the importance of these contributions to the overall health service response. And some services should not be postponed, cancelled, if at all possible, due to the acuity and potential impacts such as risk of amputation in the context of active diabetic foot disease. Some non-urgent patient contact could be postponed, but there may not be sufficient capacity in the future to catch up. So it should be acknowledged that postponement will equate to the cancellation in the proportion of cases. Specific visits for blood testing should only be arranged if the results are felt likely to change management. And the service performing the remote consultation should make arrangement for the blood testing where necessary. Also, group-based face-to-face contact should be avoided and replaced with remote contact or, if necessary, one-to-one face-to-face contact. We should also avoid unproductive attendances at hospital. Also, senior decision-making and the first point of contact should reduce or even prevent the need for further attendance. We need to also make sure the availability of medication and that the medication is delivered to the patient even during the detention and staying at home. And we need to make sure that the patient has enough supplies that include blood glucose monitoring and insulin pump consumable. Also, patients should have the tools and knowledge to control their diabetes, particularly during the sick day management. For ER visits, the following recommendations should be followed. The medical team or health professionals should advise their patient to visit the ER in the following conditions. First, if they have symptoms and signs of diabetic ketoacidosis or hyperosmolar hyperglycemic syndrome, such as nausea or vomiting, abdominal pain, acetone smelling in the mouth, dizziness or altered level of consciousness, hypotension, and finally dehydration. Second, if the patient had symptoms of acute microvascular complications such as coronary vascular disease or critical limb ischemia, or sudden change in the mental status, weakness of the facial muscles, facial droplets or slurred speech, chest pain, sudden palpitation or shortness of breath, sudden limb pain, or paresthesia. And if the patient had symptoms of infected diabetic foot, such as wound with foot redness or pus. And finally, if the patient had symptoms of retinal detachment, such as sudden change in the vision, presence of flashes and light. Indication for admitting patients with diabetes and COVID-19. First, we need to avoid unnecessary admission during the outbreak of the virus unless the patient has one of the following risks. First, life-threatening acute complications such as DKA, hyperosmolar hyperglycemic syndrome, or severe hypoglycemia. And if the patient had a life-threatening acute macrovascular complication or sight-threatening complications such as retinal detachment and limb-threatening complications such as infected diabetic foot, acute limb ischemia. For inpatient management of COVID-19 infected people with diabetes. First, we need to intensify the COVID-19 treatment and support as per approved guidelines, and to intensify the glycemic control as per diabetes management guidelines. The patient should be seen and managed by the most senior physician because senior decision-making at the first point of contact should reduce or even prevent the need for further attendance. And the medical team must expedite treatment to avoid delay and expedite the discharge to minimize the length of hospital stay. General advice for managing diabetes during intercurrent illness. First, for the sugar. The blood glucose level can rise during illness even if the person is not eating. Advice to increase the blood glucose monitoring if the person has access to it. And diabetes medications such as sulfonylureas and insulin dose can need to be increased temporarily during illness to manage these raised glucose levels. For insulin, never stop insulin or oral diabetes medication. Also, insulin doses may need to be increased during illness, specifically if ketones are present. And specific advice for people on insulin therapy is available over in the following slide. For carbohydrate, we need to ensure the person maintains hydration and carbohydrate intake. If the person is not able to eat or is vomiting, we need to advise the patient to use replacement meal with sugary fluid. And if the blood glucose levels are high, maintain fluid intake with sugar-free fluid. And if blood glucose levels are low, encourage regular intake of sugary fluid. And finally, for ketones in type 1 diabetes, advise to check for ketones every 2 to 4 hours and give extra rapid-acting insulin doses in addition to regular dose based on total daily insulin dose if the ketones are present, and advise to drink plenty of water to maintain hydration and flush throughout ketones. For people who are using insulin, if the patient was feeling unwell and with type 2 diabetes, they need to test the blood glucose level. If the blood glucose was less than 13 millimole, they need to take insulin as their normal dose and take carbohydrate as meal replacement and sip sugar-free liquid for at least 100 milli per an hour if able. But if the blood glucose level was more than 13 millimole, they need to take carbohydrate as a meal replacement and sip a sugar-free liquid for at least 100 milli. For persons with type 1 diabetes, they first also need to check for blood glucose level and for ketones presence. If the blood glucose level was more than 13 millimole and either no or low ketones level, using a urine ketone test or a blood ketone monitoring, they need to also take carbohydrate as a meal replacement and the sugar-free liquid. While if the blood glucose level was more than 30 millimole and ketones were present at more than 1.5 millimole, they also need to take a carbohydrate meal replacement and the sugar-free liquid. But if the blood glucose level was less than 13 and there is no ketones, they need to take their insulin dose as normal and take carbohydrate meal replacement and the sugar-free liquid. After taking the carbohydrate as a meal replacement and sugar-free liquid, they need food, insulin, and fluid to avoid dehydration and serious complication. So if the blood glucose level was between 13 to 17, they need to add 2 extra units for their insulin dose. And if it was between 17 to 22 millimole, they need to add 4 extra units to each dose. And if the blood glucose level was more than 22, they need to add 6 extra units to each dose. Afterward, after 4 hours, they need to retest for blood glucose level and repeat that every 4 hours. And if it was more than 13 millimole, they will repeat the process. But if it was less than 13, the illness is resolved and the adjustment of the insulin dose back to normal is required. For patients with type 1 diabetes who have a urine ketone positive or a level between 1.5 to 3, they need to adjust their insulin dose also. And even if the urine ketone level was more than 3, the following adjustment in the insulin dose should be made. If they were using the 14 units daily, they need to give an additional 10% of the rapid-acting or mixed insulin every 4 hours by increasing it by 1 unit. And if they were using 15 to 24 units, they will add 2 units. But if they were using 25 to 35 units, they will add 3 units, and so on. They will add 10% of their insulin unit. But if the urine ketone level was more than 3, they will add 20% of their insulin dose every 2 hours. And if the blood glucose level afterward is corrected, then they will return to their normal insulin dose and discontinue the treatment. Being acutely unwell with a suspected or confirmed COVID-19 require adjustment to the standard approach of their diabetes management. Early in admission, the key differences between the management of a normal admission for a patient with diabetes and for a patient with diabetes and the positive COVID-19. For people with COVID-19 infection, they appear to have a greater risk of hyperglycemia with ketones, including the following criteria. People with type 2 diabetes, they have a risk even greater if on SGLT2 inhibitors, and people with newly diagnosed diabetes. For COVID-19 disease, participation in a typical presentation of diabetes emergencies, such as mixed DKA and hyperesmolar state. The suggested action in these cases is to check the blood glucose in every patient on admission, to check for ketones in people with diabetes who are admitted, and people with the blood glucose level more than 12 millimole on admission. In these cases, they need to stop the SGLT2 inhibitors in all people admitted to the hospital and consider using 10 to 20% glucose where ketosis persists despite treatment in line with the usual protocol. In severe illness on admission, people will often need fluid requirement that can differ in those with DKA or hyperglycemia and evidence of lung leak or myocarditis. The suggested action in these cases that after restoring the circulating volume of the rate of fluid replacement regimen can be needed. can need to be adjusted where evidence of lung leak or myocarditis, and we need to contact the diabetes specialist team early on, and we need to have early involvement of the critical care team to manage the case. In all inpatient areas with diabetes and COVID-19, infusion pump may not be available to manage hyperglycemia using intravenous insulin, as these are required elsewhere, for example, in the ICU for sedated patients. The suggested action in these cases is to use an alternative sliding scale regimen to manage hyperglycemia, mild DKA, and contact the diabetes specialist team for support. In the ICU, there is a significant insulin resistance seen in people with type 2 diabetes in the ICU setting who are also positive for COVID-19. In these cases, IV insulin protocols may need amending, as people seen requiring up to 20 units per an hour. Also, patients often nursed born, so feeding may not be accidentally interrupted, and paradoxical risk of hypoglycemia. COVID-19 infection in people with or without previously recognized diabetes increase the risk of the emergency state of hyperglycemia with ketones, diabetic ketoacidosis, and hyperosmolar hyperglycemic state. For management of acute diabetes at the front door of the emergency department and acute medical unit. First, we need to perform patient assessment, the ABCDE, as we need to know there is shortness of breath that can also be due to metabolic acidosis such as DKA. We need to ensure all newly admitted patients are evaluated for diabetes and glucose measurement in all patients and ketone check if known diabetes or the blood glucose level is above 12 millimole. Also, we need to stop SGLT2 inhibitors, the CANA, the DIPA, the EMPA, or the erythroglyphosine, and metformin in all patients. And we need to review the safety of continuing the ACE inhibitors, ARBs, and NSAID. If the blood glucose level advice known or unknown diabetes, if the blood glucose level is less than 4 millimole, then hypoglycemia and follow the guidelines for treatment of hypoglycemia. While if the blood glucose was more than 12 millimole or a patient is a known case of diabetes, primary diagnosis to urgently consider first DKA, defined as a blood glucose level more than 11 millimole, or a history of diabetes with blood ketones more than 3, or urine ketones more than 2, and the pH less than 7.3. We need to also note that glucose can be normal in people using SGLT2 inhibitors associated DKA and in pregnancy associated DKA. Also, hyperosmolar hyperglycemia, we need to consider it in the primary diagnosis. We need to follow the guidelines if either of the above is confirmed and involve a diabetes team as soon as possible to change the usual fluid replacement regimen that can be necessary. Also, never stop the basal insulin in person with a known type 1 diabetes or DKA can result. In other urgent cases of hyperglycemia, we need to consider the new presentation of diabetes, either type 1 or 2, age and weight of irrelevant for either. We need to also consider sepsis and missed or delayed usual diabetes treatments such as insulin pen or insulin pump problem. Also, we need to reflect of uncontrolled diabetes or inappropriate treatment regimen and the use of oral steroid. Persistently high glucose level may need treatment with subcutaneous or intravenous insulin solutions, and if an infusion pump is not available for IV insulin, then seek advice regarding the use of alternative subcutaneous regimen. And in all cases, if unsure, please seek the diabetes team guidance as early as possible or follow the local protocol. For the blood ketone level advice, If the blood ketone level was less than 0.6 millimole, this is considered the safe level, while if it was between 1.5 to 2.9, this is at increased DKA risk, and we need to use PO or IV fluid, and consider rapid-acting insulin if the glucose was above 16 millimole, and 1 unit of rapid-acting insulin typically can be expected to lower the glucose by a percentage between 1 to 3 millimole. Afterward, we need to recheck the blood glucose, the blood ketone level after 2 hours. For blood ketone level between that is 3 millimole or greater, then we need to check the pH level and bicarbonate, either venous blood gases, and if DKA is confirmed, if high ketone is accompanied by one of the following. The blood glucose level is more than 11 millimole, or the patient has a history of diabetes, and the pH level less than 7.3, or bicarbonate level that is less than 15. Also, we need to note that glucose can be less than 11 millimole if the patient is using SGLT2 inhibitors treatment, or the patient is pregnant, or having a severe COVID-19 infection. We always need to ask the patient if the patient is using insulin and continue the use of long-acting basal insulin at all times. For patients who are very sick or not eating, they should have variable rate intravenous insulin infusion using the sliding scale with the usual basal subcutaneous insulin continued alongside. If an infusion pump is not available or for IV insulin, contact the diabetes team or follow the local protocol for an alternative subcutaneous regimen. If the patient was using a wearable diabetes technology, and if the patient was unable to manage their personal insulin pump and no specialist advice is immediately available, then we need to start basal insulin bolus regimen, then remove the pump and store it safely for further use. If SC regimen required and not able to find out the total daily insulin dose from the pump, then the following would be safe to follow. First, we need to calculate the total daily insulin doses using 0.5 unit per kg and give half of the total dose as a basal or background insulin and the other half as a bolus mealtime rapid-acting insulin. For an example, 0.5 units multiplied by 60 kg will give us a total daily insulin dose of 30 units. Half of this, 15 units, will be given as a basal insulin dose and the other 15 units as a bolus insulin divided as 5 units at each meal. We also need to ensure that the pump is disconnected after the SC basal insulin is given, and continuous glucose monitoring and freestyle Libra device can be left on the patient, but conventional calibrate glucose monitoring will still be necessary. For imaging, insulin pump, continuous glucose monitoring, and freestyle Libra devices need to be removed for magnetic scan, such as MRI. For footnote, always need to exclude acute foot infection that may be the source of the sepsis or critical limb ischemia. And always ensure foot intact and protected, and take action on acute foot disease as per the local diabetes foot protocol. for cardiovascular disease and COVID-19 patient. The COVID-19 pandemic devastated the world given it is a fast spreading, affecting a huge percentage of the population. And patients who present in the most severe form of this disease are in their majority elderly patients with multiple comorbidities or diseases. The rapid spread of the disease has overwhelmed the medical facilities around the world, causing a sudden high demand for inpatient and intensive care beds, as well as the need for trained, skilled medical staff to care for these sick patients who has also resulted in an increased need for the PPE for the medical staff. To face this high demand and to accommodate the increased need for the Ministry of Health had to reduce the elective admission, manage the patients thoroughly using virtual care, and delay the less urgent cases, and change our strategies of management. Studies found that patients with established cardiovascular disease who are infected with COVID-19 have a higher risk of mortality. However, most patients who need urgent and emergent cardiac care present with typical cardiac symptoms and don't necessarily fit the case definition of COVID-19 patients. For infection control precautions for all AMI patients who present during the COVID-19 pandemic. All patients presenting to the ER with signs and symptoms of acute myocardial infarction as a walk-in or through the ambulance system or referred from another hospital should be treated as a suspected case of COVID-19 until proven otherwise. During all emergency acute myocardial infection procedure, proper hand hygiene should be followed at all times. Also, personal protective equipment such as gowns, gloves, face masks, eye shield protection with aerosol protection such as N95 for the entire staff caring for the patient should be available. And the negative pressure cath lab should be used if not available. A HEPA filter should be used and be placed near the patient head. And all AMI patients preferably to be admitted to a single room with negative air pressure or a HEPA filter should be used if negative pressure room is not available. And all patients entering the cath lab or the CCU or the cardiac ward should be wearing a face mask if tolerated. Terminal cleaning and sanitation in the cath lab must be conducted at least 1 hour after the patient leaves the procedure room. This will allow the aerosol in the room to settle down. Also, extra care should be ensured that the healthcare facility cleaners should be provided and be supervised to wear appropriate PPE for terminal cleaning. And all patients presenting with STEMI should be considered as COVID-19 positive case until proven otherwise by either the sound clinical decision or through PCR testing. During COVID-19 pandemic, BCI or fibrinolytic therapy are considered appropriate therapies. And the choice should depend on many factors and is left to the decision of the consultant interventional cardiologist. Factors such as time of the day presenting, the clinical status of the patient, the availability of the cath lab, room availability and availability of PPE, and the ability to perform the procedure in a timely manner should all be considered. All these are to be considered when making the decision about primary BCI or fibrinolytic therapy. Also, the cath lab activation for primary BCI should not be done until the consultant interventional cardiologist has reviewed the case and the diagnosis is confirmed. And patients who are tested positive or who are considered highly suspicious of COVID-19 with severe pulmonary decompensation due to COVID-19 related lung injury, sepsis, or multi-organ failure that develop the STEMI would most probably not benefit from the emergent reperfusion strategy nor the advanced mechanical support. For those patient compensation, medical therapy is appropriate. Also, all patients presenting with non-ST elevation myocardial infarction should be considered as COVID-19 positive until proven negatively by either the decision of the clinical supervisor or through the testing. All NSTMI patients should be treated medically for 48 hours. And if the patient has refractory symptoms such as heart failure, cardiogenic shock, ventricular arrhythmia, then angiography with appropriate revascularization should be considered. Patients who are tested positive or who are considered highly suspicious of COVID-19 with severe pulmonary decompensation due to COVID-19 related lung injury, sepsis, multi-organ failure that developed in STMI, most probably will not benefit from the emergent refibrillation strategy or the advanced mechanical support. For those patients, compensation medical therapy is appropriate. Echocardiography should be restricted and should be reserved only for COVID-19 patients with NSTEMI when mechanical complication or cardiac tamponade is suspected. For patients with acute myocardial infarction in hospital with no cardiac capability during COVID-19 pandemic. All these patients presenting with the clinical signs and symptoms of myocardial infarction should be considered as COVID-19 positive case until proven negatively by either a sound clinical decision or through testing. And in hospital with cardiology service, the diagnosis should be confirmed by the consultant cardiologist. Also, in hospitals with no cardiology service, the case should be discussed with the consultant interventional cardiologist at the nearest cardiac cath capable center. Also, coordination for these patients should be directly with the cardiology service, and the decision should not be made by the RHD or the cluster. For patients with STEMI, they should receive fibrinolysis therapy if no contraindication. And in case of patient didn't show any sign of refibrillation, the patient can be considered for transfer to the cardiac cath lab facility. The referring team must ensure that the patient is fit for transfer and that the proper PPE protection for all the transfer staff is available and are worn by the transfer team during the transport. Also, decision and acceptance by the receiving consultant interventional cardiologist before the transfer is a must-do. And all patients with the NSTEMI should be treated medically for 48 hours. And if the patient has refractory symptoms, heart failure, malignant arrhythmia, heart block, the case should be discussed with the consultant interventional cardiologist at the receiving cardiac cath. Also, patient could be transferred if case is accepted and the patient is stable for transfer and require PPE for all staff during the process is available. And in hospitals that have a cardiology service, direct communication between the consultant cardiologist at the referring hospital and the consultant interventional cardiologist at the receiving hospital should be done. Upon arrival of the patient to the cath-capable hospital, the patient should initially be evaluated in the emergency department and probably triaged and consented before the shifting to the cardiac cath lab. For patients with confirmed or highly suspicious COVID-19 and COVID-19 related lung injury with severe pulmonary decompensation, sepsis, or multi-organ failure that develop STMI or NSTEMI will most probably not benefit from the emergent refibrillation strategy nor the advanced mechanical support. So compensation medical therapy is appropriate in such cases. So does COVID-19 have an impact on heart health? COVID-19 is first caused by the novel coronavirus known as the severe acute respiratory syndrome, and the primary effects of COVID-19 involve the lung, where it causes severe inflammation that damage the alveoli. And acute respiratory distress syndrome is the principal severe health effect and predominant cause of death from COVID-19. For people who develop ARDS generally need ICU admission and mechanical ventilator support to breathe. However, COVID-19 and its treatment also can cause the following cardiac complications. First, myocardial injury. It can occur from the infiltration of the COVID-19 into the cardiac myocytes, the heart muscle cells, or from inflammation or hypoxia, which is the inadequate level of oxygen reaching the heart. This injury to the heart muscles can lead to cardiac dysfunction and arrhythmia and is strongly linked to death from COVID-19. Second is vascular inflammation. It begins in pulmonary capillaries in response to infiltration of COVID-19 into the endothelial cells. These cells respond by releasing inflammatory cytokines and vascular adhesion molecules that aggravate inflammation within the lungs and can circulate throughout the body, creating systematic inflammation, which is a hallmark for severe COVID-19. The thrombotic complications of COVID-19. It includes venous thrombosis, pulmonary embolism, vasculitis, cardiomyopathy, and finally stroke. Thrombosis related to COVID-19 can stem from inflammation and disinfection in the endothelium of the pulmonary capillaries, the platelet hyperactivation, and the plaque rupture triggered by the infection. Other complications are possible as a side effect of COVID-19 treatment, and research is still underway to understand the lingering effects that remain even after the resolution of COVID-19 infection that can have multiple effects on the cardiovascular health. Early in 2020, the American Heart Association has established the AHA COVID-19 Cardiovascular Disease Registry to collect data from sites across the country. This registry included more than 22,000 patients by November 2020, and data throughout September 30, 2020 were shared at the 2020 AHA scientific session. Research is still ongoing to better understand the clinical causes of COVID-19. The median incubation period from exposure to onset of symptoms is 4 to 5 days, but it can be extended to 14 days. The acute mild phase of COVID-19 can last from 5 to 12 days with a variety of symptoms such as fever, cough, myalgia, and fatigue. Most people gradually recover from these symptoms, but during this time, some develop dyspnea or other symptoms of ARDS and can require hospitalization. Recovery can take 6 weeks or even more. And in about 20% of the hospitalized patients in the AHA COVID-19 registry, the disease progressed, requiring mechanical ventilation or ICU admission. The AHA registry data showed in-hospital cardiovascular complication in about 99% of the people hospitalized with COVID-19. Of the COVID-19 deaths in the registry, 72% were due to RDS and 10% were due to cardiac causes. Even though that these cardiovascular complications occur in a relatively small percentage of people with COVID-19, a researcher, who are also the co-chair of the AHA COVID-19 CVD Registry Steering Committee, has emphasized that given the scales of this pandemic, the cumulative number of these cardiovascular events is still considered a large number. The impact of COVID-19 on a pre-existing cardiovascular disease. The association of COVID-19 and heart health is bidirectional. Not only does COVID-19 causes cardiac complications, but pre-existing cardiac disease can offer a factor that seems to increase the risk of more severe form of COVID-19. In the AHA registry of COVID-19, the hospital admission for people with the pre-existing cardiovascular disease or cardiovascular risk factor were common. And among this group, almost 60% had hypertension, 45% were obese with a BMI that is more than 30, 35% had diabetes, and 35% had hyperlipidemia. According to these studies, obesity can clearly increase the risk of severe COVID-19. And after adjusting for potential confounding variable, class 1 obesity with a BMI that is between 30 and 35 was associated with 54% greater risk of requiring mechanical ventilation compared with people with a normal BMI. And the risk of progressively increase is to more than double the risk among people with class 3 obesity who has a BMI more than 40 and above. And as such, obesity-related risk of mechanical ventilation or in-hospital death rises more sharply for younger adults who may not consider themselves as being at a high risk for severe COVID-19. And among people in the AHA registry, hospitalized patients with COVID-19 who were aged 50 and younger, 85% had either obesity or overweight. For people aged 50 and younger with a BMI of 40 or more, there were 36% more likely to die during hospitalization compared with people at the same age with a BMI of 25. So overweight doesn't raise the risk of severe COVID-19 as much as obesity does, but it does have some influence. In comparison with people with a normal BMI, those in the AHA registry with a BMI of 25 to 30 were almost 30% more likely to require mechanical ventilation. So COVID-19 seems to worsen the pre-existing cardiovascular disease and the underlying cardiovascular disease risk factors. And these risk factors in turn increase the risk of severe COVID-19 characterized by mechanical ventilation, ICU admission, cardiovascular complication, ARDS, or pneumonia. The pooled analysis had showed that compared with people with no comorbidities, odds of severe COVID-19 can range from 2 to more than 6 times greater in people with diabetes, hypertension, cardiovascular disease, chronic kidney disease, or COPD. For race, ethnicity, and age, Race and ethnicity are strongly associated with the severity of COVID-19. In the AHA COVID-19 registry, Black and Hispanic patients accounted for more than one half of the hospitalization, and hospitalization occurred among people at a younger age. Once in the hospital, the mortality and risk of major cardiovascular events didn't differ by race or ethnicity. And in analyzing these data, researchers concluded that the greater burden of mortality and morbidity seen in this group stems from the disproportionate exposure to the SARS-CoV-2 virus in occupational and other settings and had a greater prevalence of relevant comorbidities. For older age, it is also associated with the severity of COVID-19. In part, this relates to age-related declining in the immune function. But impaired immune function and excess inflammation also can stem from malnutrition or inactivity due to functional limitations. And pre-existing comorbidities can cause endothelial dysfunction, a pro-inflammatory state, and alternation in the innate immune response. So what is behind the cardiovascular risk? Biomarkers of acute cardiac injury and coagulation are associated with worse prognosis according to the preliminary findings from COVID-19 studies. And people who develop ARDS in the severe COVID-19 experience difficulty breathing and have a low blood oxygen, which may lead directly to respiratory failure as a primary cause of death. And as SARS-CoV-2 infected and destroys the lung cells, it triggers the local immune response with the release of cytokines attracting the macrophage, monocytes, and the T cells that promote further inflammation. A healthy immune system usually can respond to the infection, eliminating the infected cells before the virus spread and clear the neutralized viruses and the damaged cells. However, in some people, a dysfunctional immune response can occur with further accumulation of the immune cells in the lungs and overproduction of the pro-inflammatory cytokines. This can cause severe lung damage and create cytokine storm that produces uncontrolled inflammation, resulting in multi-organ damage, which lead to cardiac, hepatic, and renal system organ failure. So we will be taking a break for a Maghrib prayer and come back afterward to continue with acute myocardial injury, inshallah. acute myocardial injury. Acute myocardial injury is indicated by ECG abnormalities and elevated levels of cardiac biomarkers. High sensitivity cardiac troponin, or HCCTN, a protein that regulates the heart contraction, is the sensitive marker that begins rising within hours of heart damage. The mechanism of how this myocardial injury occurs is still unclear, but it seems to be largely attributed to advanced systematic inflammation. In a small proportion of people with COVID-19, the SARS-CoV-2 also may infect the myocardium directly resulting in viral myocarditis. Biomarkers of myocardial injury are strongly associated with mortality from COVID-19. One of the common complications is also arrhythmias. Arrhythmias and sudden cardiac arrest are also a major cardiovascular complication of COVID-19. Myocardial injury and systematic factors such as fever, hypoxia, and electrolyte abnormalities all can trigger arrhythmias. Moreover, antiviral medications and antibiotics such as hydroxychloroquine and azithromycin used to treat COVID-19 can induce arrhythmias in some of the patients. Another common complication is vascular inflammation. Vascular inflammation resulting from the cytokine storm of COVID-19 is a major factor in many cardiovascular complications. The vascular endothelium is a single layer of cells that lines the inside of the blood vessel and play a vital role in the regulation and the balance between the blood vessel constriction and dilation. Vascular permeability, cell adhesion, and finally anticoagulation. A gel-like material known as the glycolic coats the endothelium and provide anti-thrombotic service. Researchers have suggested that the cytokine storm is likely to break down the glycolic coating and contributing to endothelial inflammation and dysfunction, in addition to a significant decrease in the anti-thrombotic activity of the blood vessel lining the increased risk of thrombotic event. The SARS-CoV-2 also can directly infect the endothelial cells, leading to changes that promote vasoconstriction and thrombogenesis. Another complication is the hypercoagulability. Another complication is the hypercoagulability and increased thrombotic events. The hypercoagulability is a state of increased clot formation that occurs in COVID-19 due to elevated circulating prothrombotic factors, increased fibrin formation, greater clot strength, and decreased clot degradation. Especially in the setting of blood vessel, the endothelium can damage the end-patient embolization in bed. It can lead to increased thrombolytic events, particularly the deep vein thrombosis and pulmonary embolism, as common complication among people with severe COVID. Although arterial thrombosis is uncommon in other infections-related coagulation disorders, in COVID-19, the acute rupture or clot formation in the arteries can occur, leading to stroke, ischemic coronary disease, and acute coronary syndrome, which is defined as decreased blood flow in the coronary arteries, leaving the heart muscle unable to properly function, resulting in heart attack or angina that occurs suddenly, even at rest. Indicators of this coagulopathy are increased blood level of the D-dimer, a breakdown product of the fibrin in the blood clot, indicating the occurrence of some coagulation, but relatively normal prothrombin time and only modestly reduced platelet count. In terms of the long-term cardiac impact, in addition to acute cardiovascular effect of the COVID-19, long-term cardiovascular morbidity is a concern. The elevated cardiac troponin levels that indicate cardiac damage can generally return to normal in about a week after the heart attack. Yet a small prospective observational cohort study of people who are currently recovered from COVID-19 identified cardiac damage as 2 to 3 months after infection. Cardiovascular magnetic resonance imaging and high-sensitivity troponin levels revealed some cardiac damage or ongoing myocardial inflammation in about 60 to 80% of the patients, independent of the pre-existing conditions and the severity of the acute illness. More research is needed to determine whether such findings are replicable, whether such damage eventually resolves, and whether it is clinically consequential. Now we will be discussing the medical nutrition therapy for patients with COVID-19. With so much remaining to learn about COVID-19, the development of strategies for nutrition care at various stages is still ongoing. In the acute care for people hospitalized with severe COVID-19, the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition guidelines for nutrition therapy in COVID-19 requiring ICU care emphasizes that when a patient can't maintain adequate oral intake, early enteral nutrition in critical care can improve mortality and reduce infections. COVID-19 can impose several unique adaptations to care and to reduce the risk to healthcare provider and other patients. Procedures should be adapted to minimize the contamination of equipment and limit the exposure to healthcare providers. For example, estimated energy requirement using weight-based equation rather than indirect calorimetry. The ASPEN guidelines call for all feeding to be initiated within the low-dose enteral nutrition that hypocaloric advancing slowly over the first week of critical illness to supply up to 70 or 80% of the caloric requirements. Emphasis is on achieving high protein intake with a goal of 1.2 to 2 grams per kg of the actual body weight per day. Studies before COVID-19 pandemic has showed that even short periods of bed rest or hospitalization can result in rapid loss of muscle mass and physical function, even in younger adults after only a few days. The risk of sarcopenia is magnified by age-related anaerobic resistance to effect of activity or protein consumption, and by inflammation-related upregulation of catabolic pathways and downregulation of anabolic pathways. Therefore, the cytokine storm in patients with severe COVID-19 not only contributes directly to tissue damage, but also might contribute to sarcopenia. When oral intake is possible, severe coughing and fear of aspiration can limit people's ability to eat adequately. Therefore, attention to intake is very important. So overall, meeting the nutritional need is complicated during COVID-19 by the characteristic loss of taste and smell and poor appetite. Therefore, enhancing food flavor can improve the patient intake. Post-acute care for the nutrition care, it remains a challenge even though the highly catabolic phase of severe inflammation has subsided following the acute care of COVID-19. And when patients arrive at the inpatient rehab following COVID-19, typically they have had tremendous weight and muscle mass loss. A 20% weight loss in the last 6 to 8 weeks is not unusual, and malnutrition may have existed before COVID-19, have developed while ill before hospitalization, or have developed during hospitalization. In the inpatient rehabilitation setting following COVID-19, our first goal is to identify and resolve any malnutrition. By the time people are in the rehab setting, the inflammatory cytokines cascade has usually subsided, and the exercise they are getting has strong benefit to support the rebuilding of muscle mass. So we generally provide protein in the range of 1.2 to 1.5 gram per kg of the actual body weight, or 1.5 to 2 grams per kg actual body weight if the BMI was over 30. Meeting the nutritional need is complicated since these patients may have dysphagia following mechanical ventilation. And the transition from tube feeding to a regular diet is a time with high risk of not meeting the nutritional need. Appetite stimulants may be helpful for some patients with persistent poor intake and continued weight loss. However, they can have side effects of particular concern for people with COVID-19. For example, some appetite stimulants increase the risk of thrombolytic event, arrhythmia, or hypotension. As people progress toward going home, focus to eating habits that reduce cardiovascular disease risk factors. And by co-treating patients along with occupational therapists, we can incorporate teaching about heart healthy choices into teaching about meal planning. Also, screening for malnutrition should be a routine part of clinical care, especially for patients at greater risk, including those with functional impairment or comorbidities. For people with any cardiometabolic disease, the American Association of Clinical Endocrinologists emphasizes staying at home as much as possible and washing hands, as well as getting adequate sleep and limiting their alcohol intake. And although there are theoretical reasons for supplementation, even nutrients needed for immune function can be ineffective or counterproductive at the extremely high level. Here we will be discussing what the researchers say about the following nutrient intake. For zinc serum levels, it has been shown to be low in about 20 to 30% of the older adults in limited studies. Some studies have suggested that 30 to 45 milligrams per day for a few months in people at risk can improve the cell-mediated immune function. However, prolonged supplementation can cause copper deficiency that lead to anemia, leukopenia, or damage to the nervous system. Results from studies evaluating zinc in COVID-19 management aren't yet available, but oral zinc supplementation is likely to be safe for people who choose to take them as long as amount doesn't exceed 40 milligrams per day in adults, but safety is unclear regarding higher doses. For vitamin C, it is important for immune response, but current study doesn't provide evidence supporting the use to prevent or enhance treatment of COVID-19. Result of IV use of vitamin C doesn't necessarily apply to oral food or supplementation intake. And for vitamin D, increases expression of some immune system components and the low serum D3 levels have been linked to increased risk of upper respiratory tract infection. While vitamin D deficiency or insufficiency frequently was seen in some small studies of people with severe COVID-19. However, levels at disease onset or at 8 weeks follow-up weren't related to persistent symptoms burden, lung function impairment, or ongoing inflammation and other common diseases. Moreover, vitamin D deficiency was seen in people with factors related to greater COVID-19 severity that could be non-causal association, and some guidelines recommend 1,000 to 2,000 international units per day for people with prolonged hospitalization and limited outdoor access or serum vitamin D levels that is below 20 or 30 nanogram per milliliter. Also, mega doses don't further benefit the immunity. Another disease that we'll be discussing in relation to COVID-19 is sickle cell anemia. The SARS-CoV-2 infection presents dangers to patients with hemoglobin disorders, in particular those with sickle cell disease. The virus affects primarily the respiratory system, from the nasopharyngeal symptoms to severe pneumonia that lead to ventilation and increased mortality. The following symptoms may develop after exposure to COVID-19 infection, including cough, difficulty in breathing, and fever. These symptoms may overlap with serious complications and major causes of death in this hereditary blood disease, which is acute chest syndrome. The ACS is most often triggered by respiratory infection. And furthermore, patients with CSD with the SCD have weaker immunity for multiple reasons, including autosplenectomy and hydroxyurea treatment, which could cause further immunosuppression. The risk of acquiring COVID-19 infection would increase in patients with sickle cell disease if they are older and have other comorbid illnesses such as diabetes or cancer. On the other hand, very few cases have been reported in children. However, children with sickle cell anemia are special populations that are at increased risk due to their underlying illness. So far, very little clinical experience of infected patients with hemoglobin disorders have been recorded, and any statement on this subject may be regarded as speculations, cautionary, although these are, however, necessary. In view of the rapid spread of the virus and the possible factors which may render these patients fragile in front of these infections, the Ministry of Health believes that the health services should be alerted to these risks and affected patients warned so that the extra precautionary measure can be taken. Some general instruction for outpatient management include, if and when possible, convert all routine in-person appointment to virtual or telephonic appointment. Also, we should educate patients and parents over the telephone about COVID-19 signs and symptoms and the importance of physical distancing to limit the chances of exposures and infection. We should also educate the patient and the parents when to seek medical attention and how to seek care. Also, we should counsel the patient and the parents to continue to seek medical help for fever and other signs of infection and shortness of breath. We should also make sure that the patients have thermometers and to know how to use it and clean it after each use. And we should encourage the patient to adapt healthy lifestyle and hygiene, including hand washing, social distancing, good nutrition, sleeping well, and avoiding stress and anxiety. We should also make certain that the patient have adequate supply of all prescribed medication at home, including analgesic, and to manage both acute and the chronic pain. We should also use the local pharmacies and the Ministry of Health delivery services to deliver medications to the patient. And we should counsel the patient to adhere closely to use hydroxia, folic acid, iron, chelators, and other chronic medications that are prescribed for them. Also, we need to consider starting or optimizing the existing therapies known to reduce sickle cell pain frequency, such as hydroxyurea, as this is what most commonly bring the children and adults in direct contact with emergency departments and hospitals. Therefore, the goal in general is to reduce this contact if possible to limit their exposure to COVID-19. We will take a break now for Al-Isha prayer, and afterward we will continue with pain and sickle cell disease. Infection to increase hydration and manage pain at home with oral medications and to reduce hospitalization and visit to the emergency department. We also need to call in or prescribe the analgesic medications to the patient and ensure the delivery by the local pharmacy. We also need to call patient frequently to assess response to home-based treatment and offer them in-person evaluation if needed. We should also urge patients to continue strict adherence to medication that reduce acute sickle cell pain frequency, such as hydroxyurea, and to reduce presentation to emergency department. We should also use strict COVID-19 precautions when assessing the patient in daycare if needed. For patients with sickle cell disease and COVID symptoms, such as fever, cough, or shortness of breath, we need to schedule patient for outpatient visit immediately and to avoid the emergency department if possible. If the ER must be used, call ahead to facilitate care and isolation for the patient. We should also follow the Ministry of Health guidelines for COVID testing for confirmed or suspected case. We should also follow standards of care for managing the sickle cell disease patient and fever, including the blood and other culture as indicated, testing for typical viral infections, chest X-ray for all sickle cell disease patients who have respiratory symptoms should be retained, and administrative of imibaric broad-spectrum antibiotic to cover the encapsulated organism and as indicated. We should also assess for signs of acute chest syndrome. Management of ACS in sickle cell disease patients infected with COVID-19 include but not limited to the following. First, transfusion should be performed in patients with worsening anemia and evidence of hypoxia and chest X-ray changes. We should also initiate simple transfusion if the patient is symptomatic or there is significant anemia, if the hemoglobin level was less than 7 grams per deciliter or greater than 2 grams per deciliter fall in hemoglobin level within the last 24 hours. We should also initiate exchange transfusion for progression of hypoxia or clinical deterioration. And another broad-spectrum antibiotic, including the MRSA coverage, atypical microorganism, and pneumococcal infection. We should also consult pediatrics or adult pulmonary as well as hematology. Many patients with sickle cell disease are chronically prescribed a non-steroidal anti-inflammatory drug, angiotensin converting enzyme inhibitor, and angiotensin II receptor blockers. There have been some emerging data on the use of these agents with COVID-19 infection. For the NSAIDs, there are recent claims suggesting that there is evidence to recommend that patients with suspected COVID-19 should avoid anti-inflammatory drugs. And these drugs could be an aggravation factor for the infection, and there appears to be evidence that prolonged illnesses or complications of respiratory infection may be more common when anti-inflammatory drugs are used. Prescribers should consider the most up-to-date evidence-based information on these drugs when treating symptoms of COVID-19, as referenced on the Ministry of Health COVID-19 protocol and order sets. For angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers, it has been shown that the COVID-19 viruses uses the SARS-CoV receptor angiotensin-converting enzyme 2 for entry into the targeted cell. For ACE2 levels, it can be increased by the use of renin-angiotensin-aldosterone inhibitors, including the EIS and the ARBS. Despite these observations, the impact of current use of these two medications on the course of COVID-19 infection has been systematically investigated. And the recommendation is to continue these therapies for hypertension, heart failure, or ischemic heart disease as indicated. And given high mortality, be vigilant for signs of fat emboli syndrome. If the patient is COVID-19 negative, if possible, give the patient an insensitive spirometer to use at home. We should also follow the Saudi Ministry of Health protocol for patients who are suspected or confirmed with COVID-19 that was discussed previously. For blood transfusion in patients with sickle cell, at this time, there is no evidence that the coronavirus may be transmitted through donated blood. However, certain precautions have to be taken during donation of blood. We should monitor the availability of blood and blood products at our local blood bank closely, as we may have to adjust our transfusion practice to maintain current individual patient treatment goals. We should continue empowering blood donors in our local community and hospital to give blood, provided that there is a safe blood donation environment and served in small groups. Also, patients with sickle cell disease are at risk of alloimmunization. For this reason, there is need to provide phenotypically matched red blood cells for the clinically significant minor blood groups such as E, C, E, and K, Duffy and MNS blood groups. We should also consider transitioning to hydroxyurea for patients who are eligible according to the Twitch criteria. We should also consider modification of transfusion strategy in order to conserve the blood in the following. First, patients receiving chronic transfusion for recurrent acute chest syndrome. We should individualize for maintenance of HbS less than 30 versus less than 50, and we should consider adding disease-modifying drugs such as hydroxyurea. For patients on RBC exchange for end organ damage, parabism, or other non-neurological indication, we should switch to simple transfusion or partial exchange for 3 to 6 months or until blood supply has recovered. Thank you for everything. This will be it for today, and we will see you again tomorrow starting from 4 p.m. inshallah.